So we're here today with Matt Miclette from NeuroFlow. They have a behavioral health platform, and it's a venture-backed company, been around for about 4 years. But before we get into that, Matt, I understand that you have a military background. Can you tell us a little bit how that led you to ultimately be the director of clinical operations at NeuroFlow?
Yeah. I'm a nurse by background. I took a pretty non-traditional route through my life, particularly through my medical career. Joined the military right out of college, got to work in combat trauma, treating those that came back from Iraq, Afghanistan. Then I went on to lead the inpatient behavioral health unit at Fort Hood, which was interesting because I actually had an overlap with our current CEO at Fort Hood. So we were there at the same time, never met each other. But we both came to Philadelphia for grad school and both went to Penn for grad school. What was interesting is we actually crossed paths because we both co-founded and ran nonprofits. And that was the actual space that we found each other in, was working in the nonprofit space. And it was actually having a beer with him one night, just talking about kind of how bored I was. At the time, I was working in substance use and mental health policy for local and state governments and academia, which is very meaningful, passionate work, but it can be quite slow. And that was about the time he was like, hey, there's a great opportunity here. I think you can be a big asset to this company, which was really just scaling up at the time, just kind of starting. Best decision I made was joining the team, but just really interesting that we crossed paths quite a few times, but never actually met each other until the nonprofit work we were doing, and it was actually that conversation we had that evening where Chris brought me in, and I'm so thankful that he did. But certainly that foundational roots in the military now is a lot of what drives the company, a lot of what's in our DNA to this day.
Yeah, because if you visit your website, there is a focus on military folks and some of the challenges that they're facing. But that leads us a little bit back to the idea of addressing behavioral health. And behavioral health is a pretty large umbrella term, right? I mean, it covers a wide spectrum. Can you sort of talk about the challenges of addressing behavioral health issues?
Yeah, for sure. I think one of the misconceptions about mental health is that it's only for those with mental illness, right? And it's not, right? We all have mental health. And I think that's the approach we really try to take here, is that everyone can benefit from getting tools and resources around behavioral health and mental health. But we also never thought that we should just be throwing the kitchen sink at everybody. So the approach that we've taken is really taken a very individually tailored approach where we can identify different conditions or what would benefit each individual best, and then target the resources to them. So as a quick example, if through NeuroFlow we're able to identify that I have depression, then we can really gear content to me based around CBT, right? Maybe some psychoeducation around how my thoughts are connected to my mood, or behavioral activation to get me to socialize more and connect to my social support. But Mike, we know you're a well-adjusted guy, right? And maybe you've been doing quite well. What we could do for you and send to you is things more around resiliency or positive psychology, performance psychology, where it's much more about helping you build up those resilient skills so that you can bounce back when you do experience those challenges in life. And through performance psychology techniques, help you to perform at your highest potential, right? Which is really our goal here, is to help everyone perform at their highest potential, whether that's at work or back at home with your family, so everyone can benefit. And what we're able to do then through which we can get into a bit of the data science aspect of what we do, but is target those resources to you as an individual to best help you wherever you are in kind of your stage of life.
And my understanding is you're using risk stratification to do that, to understand. So for our audience, can you talk a little bit about the risk stratification and how that factors into the insights that you deliver to your users?
Yeah, for sure. Yeah, I mean, we do use risk stratification, which broadly speaking, risk stratification just means we are, determining which patients or members, depending which population we're working with, are most at risk of developing either a costly or life-threatening situation, right? So who is the most at risk in that population? Our methodology for doing that is we use what's called cumulative risk, right? So that's taking in a bunch of different information and gathering that information together. So that could be things like validated assessments or mood, how are you feeling today? Mood and sleep ratings. We're able to take in passive data. So you think about things that are collected through wearables. And we calculate that in what's called a NeuroFlow severity score. That's what we call it internally, and that's some of the papers we'll be publishing on are around that severity score. But really scientifically and academically, it's a cumulative risk score. And what that enables us to do is then compare patients across the population, so much more traditional risk stratification, where we know that Mike is the first person I should be reaching out to this morning. He's the one that's most acute, maybe at the highest risk for suicide or maybe high risk depression, right? But also what it allows us to do is then compare patients over time. So we can not just look at a single point in time of where Mike falls in that population, but we could also look and compare that patient and look at their trends. So a patient who consistently has moderate depression is probably not at the same risk as somebody who's been trending upwards, where they went from no depression to mild depression to moderate depression, right? So these trends are incredibly valuable rather than just looking at single metrics in time, actually looking at the trends themselves and how the individual is doing.
And do you look at changes in behavior or online behavior as an indicator that something might be happening?
Yeah, for sure. We do that in a couple of ways. So we certainly utilize what's known as natural language processing or NLP, right, for those in the AI business.
Yep.
So that's certainly one tool we use. So we can look at things like journaling, journal prompts, look for changes in language and behavior there. So certainly if I'm starting to escalate my word choice and start talking more about self-harm or suicide or things like that, we can surface it. So absolutely, especially through the free text, able to do that. But also looking at, we always say everything's a data point, right? So even people that aren't logging in and engaging when they previously had, right? Even that for a provider is information. So while we have super high engagement rates that we hang our hat on, we also know that we can send alerts that, hey, this person, was engaging a lot, but now it isn't so much. Or we can look at step count. Maybe they're averaging around 9,000 steps a day, and now it's been like 300 the last couple of weeks, which, maybe that's sign of depression or bipolar disorder, cocaine use disorder, maybe it's bumping up to 50,000 steps a day or higher. So using that a lot of different ways, we can really look at behavior, both in terms of on the platform and then again being able to collect that passive data and pulling it in as well.
And then I'm guessing that the platform, it has a lot of folks that could benefit from this, right? Because you have the providers, you have the end user, you have the healthcare organizations. So can you sort of, in 2 seconds or more, sort of outline sort of the different players and how they would utilize your platform? Yeah,
for sure. In short, what our goal is to enable the delivery of evidence-based models. So you can think about behavioral health integration, which is bringing behavioral health into primary care and physical health settings. That's our goal. So our goal is to make it much easier to do that. So the term we use here is TBHI, technology-enabled behavioral health integration, where traditionally models like psychiatric collaborative care, which has just an amazing amount of research as far as reducing cost, improving health outcomes, improving patient experience, right? We think about the triple aims of healthcare reform. Yet it's a very difficult model to deliver. It's very labor intensive. There's a lot of change management that needs to happen, and technology and probably the most burdensome thing is just that you need to make phone calls. Every single patient needs to have a phone call and outreach in this model. And I can tell you right now, especially at this time of the election season in the US, right? I'm not picking up my phone when it's an unknown number because we're getting calls all the time from unknown numbers at this point. So, so being able to really drive and automate a lot of this process so that when the behavioral health care manager in that model is spending their time, they're doing the really meaningful work of problem-focused therapies and what's going to make those changes and outcomes, and not focused on just doing screening and not struggling to assign homework and things like that. We're automating the process that doesn't need to be labor intensive and making it much easier to streamline all that data into the EHR and registries where that data needs to populate. So, long story short is our goal is to make behavioral health integration from everything from screening all the way through to psychiatric collaborative care, a much more seamless process from end to end, really creating that whole solution.
And is the intent that the product's a standalone for individuals, or is this something that is, mixed into treatment options, another modality of treatment to add to their care plan?
Yeah, I always like to say that we're not here to replace anybody, right? We're an adjunct to treatment. So where you might already have a great psychologist on staff, we're not here to come and replace them, right? But what we're here to do is amplify their effect, so that when they can make sure that there's we talked about risk stratification, so that they're spending the time on those patients that are most acute, so that when they deliver homework, it's actually being engaged with, because there's a lot of evidence to show that if you do, particular treatments, whether it's CBTI for insomnia or the like, that if patients do the homework, they get better. But too often people are not doing the homework, right? So we make a lot of that easy and automated. And what I really love about us and NeuroFlow is that psychologist doesn't have to take what Matt says is the best care. They can actually change the content and customize it to what their own practice is. So, I think the long story short is we're creating a big feedback loop here where all of that data is coming back to the provider. The provider is then an informed person being able to practice measurement-based care and can then deliver the best activities and measurements back to that patient. That can be done automated, but again, that's a lot of what the clinic wants. And we're here to be flexible in order to fit with whatever existing infrastructure is in place, or bring those additional services. So we can bring in, behavioral health care managers, psychologists, psychiatrists into the practice if that's something they need. But we're here to be a turnkey solution, but we're not here to tell you how to do it. We're here to help you, guide you, and help you develop those workflows and procedures in order to do it.
And I'm assuming, and I guess I shouldn't do that, but that it tends to be more holistic, right? Because if I only see my care provider once a month or once every 2 weeks, and they ask me how I'm doing, I'm going to tell them how I'm doing that day. Right?
That's right.
Where you are monitoring them over time, and you're getting more of, probably more of a bigger picture of how they're doing with their behavioral health. Is that correct?
Oh, that's absolutely right. I'm sure if you asked me, without looking at NeuroFlow and looking at my trends, how have I been sleeping? I'm going to think about the nights I slept bad, right? And we tend to do that as humans. We tend to focus a little bit on the negatives and kind of what's gone wrong over the last couple of weeks. But what this does is offers an opportunity to point out individual days. Well, what happened on Tuesday? Tuesday, you seem to have a good night's sleep. Was there certain things maybe you did before bed, sleep hygiene wise, that are working for you, where maybe we can replicate that effort? So not just focusing on what went wrong, but now we can identify, well, what's going right? And that's a big part of being able to track these trends, not just month over month, but now day over day, to really, to your point, right, to really capture what's going on in that patient's or member's life.
And one of the things, particularly around mental health, is that there's still some stigmas around mental health. How does this help people who have concerns or aren't quite ready to talk to a provider? How does this help them?
Yeah, that's a great question. There are certain populations we work with that come right to mind with this example. So we touched on the military. We're used by the Air Force. We're used by first responders, right? And this is my background. These are people I'm used to working with, and I loved it because it was such a challenge because of this stigma issue, right? And what we do is a few things. First is we talk about it in context of health, right? It's not mental health and physical health, it's health, and the interconnectivity there between the two. So understanding that if you want to perform better in the field and be the best airman you can be the best, we work with, the best law enforcement officer you can be, then you need to take care of your mental health. And then also doing a lot of education. And what I like to say is, if we identify somebody that has depression and they don't want to seek treatment, maybe they're not ready to seek treatment, that's okay. But what we want to do is make sure that they understand that this is a common thing. They're not alone in this, that there is help, that there is reason for hope, and that there are effective treatments, right? So if we can help people start to understand that the resources are available, that this is a curable disorder, and that there is opportunities for you to get better. If we can continue to help them learn that it's not what that is like and what the process is like, then we can slowly bring them back to our side. And then we actually have care coordination team that can then connect them with the care. So we've had great success in actually connecting folks directly to that treatment to get them in therapy that day. And I think a lot of that has to do with kind of using a digital technology where you can kind of explore this a little bit. You can tip your toe in the water and not feel like you're going full on into needing a therapist. You can at least understand what this is about and what to expect when I do enter a therapist's office.
So what happens when you recognize that somebody is truly having an acute event where that might be harmful? Can you intervene, or do you have to rely on them to, take the actions themselves? What do you do in that
Yeah,
situation?
for sure. I have to say, that's probably the question I get asked the most, right? Because that's what everyone wants to know is in the moment of crisis, what do we do? And a few things are happening immediately. First thing we're doing is the first thing that patient's going to see up on their phone screen, or we have a web version as well. So up on the web is the crisis resource lines, and you can't click away from that screen without at least viewing those crisis resources that are available. So whether that's a new, National Suicide Prevention Lifeline, we can also populate it to be something more veteran specific with the Air Force. Next thing that happens is then they're actually being immediately assigned a curriculum on developing a safety plan. So even if I'm not able to reach out at 3 in the morning when we identified this behavior, we can then give them activities and the resources to do right away. So then they're thinking about, well, who can I speak to? Who is my social support that I could reach out to and connect with? Right? What does these thoughts of self-harm really mean? Is something wrong with me? Right, so giving them the education around that. And then we populate, depending on the procedure, this is where it can vary by organization, right? But we'll then populate, make sure that that message is received by that clinic very first thing in the morning, so that they're then able to call first thing when people are actually back in that office. So for some clinics, that might not be till a Monday morning, right? And there is a possibility this will happen on the weekend, but way more likely to happen on Wednesdays, because that's when we usually deliver that's usually when we get the highest engagement.
It's only Monday, I have 2 days to go, okay.
Yeah, so Wednesdays are actually our golden day. But it can happen on the weekend. And what we always say is it's much like if someone called the clinic and left a voicemail, right? We treat it much in the same way, that we're going to make sure that they have the resources right away. And then as soon as we can, someone will be calling. So every morning, my care coordination team reaches out to those that are under our care in order to conduct a suicide screen. Because oftentimes it's not that they necessarily have suicidal ideation. It's just that they're burnt out, right? Having thoughts of being better off dead is not the same as having being actively suicidal with a plan. So we'll do a proper suicide assessment and determine what is the best level of care and next steps for this individual. So, it's always someone who worked in inpatient psych, I'm always like, let's not overreact first, right? Because that's just going to stigmatize this further. Let's do a thorough assessment, understand where this person needs to go as a next step. So that's what we do, and that's what my LCSWs, my licensed professional counselors are trained in doing.
And then you said earlier your goal is evidence-based. So how long have you been doing this, and what kind of results have you been seeing?
Yeah, so our company's 4 years old. We've seen some great evidence. So just last month, I lose track of time in the startup culture, but just last month or the month before, a large health system that we work with did their own data poll. So we're in 26 of their clinics, everything ranging from maternal health. So you can think about OB, where we're doing pregnant women and new mothers, to their psychiatric clinics, their addiction clinics, their multiple other specialties that we're in. They did a data poll where they compared a control group and an experimental group. They matched them based on demographics and geography. And they found that members who utilized NeuroFlow had a 34% reduction in ED utilization. And when you talk in terms of cost savings, that's phenomenal. We also worked with a number of pain practices. So chronic pain is actually an area that makes sense that we'd be working in, because there's a high co-occurring physical pain and then mental health disorders. And with a data poll we did with one of our large systems we work with there, we found well over, I think it's close to a $1,500 per patient cost savings, because they're on a value-based contract arrangement with their payer. So that benefits everybody, right? That's benefiting the clinic, who's getting some of that back through shared savings. That's benefiting the payer, who now has to spend less for that patient. And that's benefiting the patient because they feel better and don't need to seek as much care. So we're seeing a number of different outcomes in terms of utilization cost. And then when it comes to outcomes, we see 50% meet depression remission that have depression. So that means that they had at least a 50% reduction in their depression scores within 4 to 8 months, which is a HEDIS metric. So it's a quality metric that's utilized for pay for performance bonuses and the like. So seeing pretty phenomenal outcomes kind of in all domains.
And you've been alluding to sort of this idea of the value-based care model, right?
Yeah.
Better outcomes, greater efficiencies, reduced care costs. How much of that is driving sort of how you look at this market?
Yeah, I think it's interesting. Certainly when you're first starting out, right, you get your foot in the door with the fee-for-service model, right? And I think what's interesting is we never had to change our approach because from day one, we were all about patient outcomes, and we were all about how do we make life better for patients. So we've never really changed the product itself much. I think our marketing and sales has changed quite a bit because now it's less around, hey, look at these revenue codes that we can drive, right? Like these procedural codes, but because those procedural codes were already tied to cost savings. So a lot of the services we were offering were already the foundation was around being a value-based delivery system. It was just being reimbursed in a different way. So now we're just kind of changing our messaging quite a bit more. But regardless, it's still all about the behavioral health integration because that's where value-based arrangements are moving toward, and now it's more and more also being reimbursed from payers as well. So it kind of is one and the same as far as our approach and our product, but certainly I'm sure the messaging is quite a bit different now than it was probably even just a few months ago.
And I know you said earlier that the question around the acute care was your number one question. So I'm assuming your number two question is COVID. And how does that impact? Yeah. And how are you addressing the challenges around COVID?
Yeah, absolutely. So quite a few ways. One of the first things we did within the first couple of weeks of the COVID crisis back in March was including some measures for self-isolation. So thinking about loneliness, right? How do we identify those that are at home and don't know where to go? So one of the new social determinants that we certainly identify and populate now is around loneliness. And again, to the point where we cannot just identify that, but then we can actually trigger content automatically to those people around what can I do when I feel lonely, right? What is available out there for me as an individual? So that's one thing certainly we're doing. And then I think, again, a lot of our strategy around depression and anxiety, the treatments don't change, right? So there's going to be higher incidences of depression and anxiety right now, and we've seen that through our own data. But the treatments for them pretty much consistent, right? So it's much more about understanding that there's higher rates, and that if you want to be able to treat this at scale, right? Whether you're a large academic institution or a small clinic, right? You're going to need help. We don't have enough therapists out there to meet the demand. So how do we work on prevention, which is a big key for us, is to get everybody on board so we can work improving their resilience and get the prevention skills. But also have them ready for day one when they do go in a therapist's office. So identifying those people that have depression, giving them some psychoeducation. What do I expect on day one? How do I make this a successful journey for me? So I think that's really how we're helping with COVID. Again, is focusing on what we do best, which is identifying these folks, getting the care they need, and then immediately giving them really the individual tailored resources for them.
So the value-based care model, there's three players and they each sort of have a portion of it. So obviously the payers are interested in the reduced cost and, changing the cost of care. Providers, they're looking for efficiencies in their own organizations because, like you said, they're overwhelmed, they're overstaffed. They're looking for better outcomes. And then the patient, is looking for that. Who's the primary driver of your product? Is it payers because they recognize the cost savings? Is it the providers? Who's the primary driver?
Yeah, that's a really interesting question. I think largely when we think about these models and how they're being delivered, it has to be provider-led. So when we see the best outcomes, we've worked in population health settings and we've worked more in those kind of provider-driven models. We're pretty firm believers that provider-led models are the way to go because they understand their patient population. The focus of the evidence has been around these type of models, but we also know that the payers are the ones that benefit the most, right? So there's kind of a construct that we're working on where, yeah, we're working with the payers, but how do we then get them to support the actual providers, right? And there's a couple different ways we're looking at that. But ultimately, we're able to take it from both sides. So we're working with large health systems, particularly, again, back to the value-based contracts. They're a big opportunity for us as a company, and I think we're a big opportunity for them in terms of cost savings and delivering these models. And then also working with the payers understanding that if we can help their providers, their in-network providers, to deliver these behavioral health integration models, they're going to see huge cost savings, particularly for those with other chronic conditions where you are 2 to 3 times more expensive if you have hypertension and a mental health disorder, right? So how do we help?
And there's
people?
a great comorbidity between the two, right? So
huge. Yep, same thing. I mean, depression, diabetes, even things you wouldn't think of, like anemia, huge opportunity there with those populations. So I always tell people that Milliman is certainly a great reference for looking at cost savings and opportunity. It's a report that's came out every last few years. Last one was 2018. But either way, long story short is, I think everyone, like you said, everyone has an interest here. But I do think provider-led is the way to go. And then I think as we can include more payers in that, in supporting that, understanding that they're the ones that are largely going to benefit from this through the cost savings themselves.
And does this give the providers, sort of, I was going to call it a reminder, but just to sort of address the behavioral health? Because what will happen is the cardiologist is very focused on your heart health care, right? But of course, we know that there's a huge correlation with that and depression, which tends to get put off, till later or ignored. Does this help the providers sort of remember that, oh yeah, behavioral health is an issue and it's going to affect the outcome?
Oh, 100%. I think what was really a game changer for us was the EHR integrations, where now, I don't expect a cardiologist to be logging into a third platform, right? Where they already have limited time. So now that we can bring what we produce for each patient is a monthly report. So what's been going on with the last month of this individual and how are they trending, right? What were their last assessment scores? And then actually able to auto-populate clinical recommendations as well. So based on how this patient is trending, maybe we should be considering some medication and referral to treatment, right? Whatever that is, and then can give further guidance on how to do that. So we're not just helping them.
The knowledge gaps potentially.
That's right. That's exactly right. So really helping them to understand, what can I do as a primary care provider when I don't feel equipped to be able to handle this? We can give them the data, we can give them suggestions, and we can walk through how to actually do that. And then also be able to offer the services certainly on top of that, where, hey, I don't feel like I have maybe the bandwidth to be able to do that. Then we also have services where you're going to get reimbursed for doing these behavioral health integration models, right? So what we can do is then help you with the staffing as well, if that ends up being a limiting factor, which is sometimes the case. But ultimately being able to drive all of that data back to their EHR where they're already going, part of the appointment workflow where it feels natural, and then making them feel more empowered with giving them suggestions and resources they need.
So behavioral health is difficult to sustain, right? Or the changes to behavioral health are difficult to sustain. And one of the things that we're seeing is that, people were relatively satisfied with going online and doing a lot of these telehealth, telemedicine things online, but because they're also getting tired, right? Because this has gone on much longer than anyone had anticipated. How do you deal with, sort of fatigue around your platform or your product?
Yeah, that's interesting. I think there's a few ways. Our platform is incredibly engaging, and I'm not just tooting our own horn. We have 76% of the people engaged, after 1 month. It's 50% at 6 months, which when you look at digital health solutions, that's phenomenal, right? That's better than good. And we do that through a lot of behavioral economics kind of approaches. So you gain actual real life rewards in there that you can actually redeem. You're gamified. It doesn't feel like a sterile clinical experience. Not to throw the VA under the bus, the VA has a lot of great mobile apps, and I don't know if anybody's not US based. The VA is our Veteran Affairs, US Department of Veteran Affairs. They have 16 different mobile apps that are great. They're research based. They're backed, 16? But none of that data is feeding back to the provider. What's that?
16.
Oh, that's at last check. I have no doubt there's more. But there's one for every condition, right? So if I have multiple conditions, I need to have multiple apps. None of that is feeding back. It is not engaging. I'm not getting rewarded, right? And these are the things we're trying to solve for. Is right now the status quo is not great in digital health, particularly for mental health. So how do we make
this is a very fragmented market, is it not?
Oh, for sure. for sure. That's why we want to be that all-in-one stop, right? We think that you shouldn't need to log into multiple platforms if you're a provider. You shouldn't have to go to multiple stops if you're a patient. How do we make this a much more seamless and fun, right? It shouldn't be a challenge. We can make this where it's an engaging thing that you want to be doing for yourself to better yourself, and that's our goal.
And that's usually the biggest critique we hear from providers. Like you said, they don't want to learn another platform. They don't want to do more data entry. So, if you like you said, the integration is crucial. So tell me a little bit about the company. Sorry. So you guys are venture backed, correct?
That's right. Yep.
So tell me, were you involved in the fundraising and?
I mean, to the extent of me being the clinical expert on the team, but certainly was not the one fundraising ourselves or myself. But certainly I've sat in on some of the diligence meetings and things like that.
Okay, but so you've been through the venture capital process.
Okay.
I understand you weren't the key point, but any thoughts about that in hindsight, or?
Yeah,
we won't show the VC, and we won't even mention them. So.
Yeah, no, it's great. It's very new to me, right? So I'm a clinician by background, military setting where it's a single payer health system, right? So coming in and learning about venture-backed companies has been exciting for me. So I've learned quite a bit, and I think what's been the best for us is we've been revenue generating now for over 2 years, right? So we've never had to go out and feel desperate and feel like we have to beg for the money to stay alive, because it's never been the case for us. We've been able to sustain a business, but we use that capital, that venture capital that we're able to raise, is just putting us in hyperdrive, right? So it's not so much that it's out of desperation for us, but it's about going out and finding the right strategic partners that want to help us on the common mission to help people feel better faster. So I think that's what's been great about this experience, is understanding that if you can put yourself in a situation where you have time, you have the runway to go out and find the right partners, that's much more important. So I think getting out there early before you're in desperate mode, always be fundraising, right? We're always speaking with people, whether we're raising or not, about what's going on and keeping them updated. I think that's the best thing you can do, because you don't want to, the last thing you want is to be begging for money and having to take a low evaluation from partners that are not going to help you in your goal. So, as we move to Series B, that's what we're going to be looking for. Is we're not desperate. We're going to take our time. We can find strategic partners that are going to help us with our goals of helping people.
And what does the product roadmap look like? What can we expect on the horizon? Tell us a little bit about that.
Sure. Yeah. One of the things that's coming out very, very soon, next few months, is what we call enterprise architecture. So while now we can look, one clinic will have a platform, all of these clinics can now connect together so that we can feed up and have, large data reports about what's going on at clinic A, B, and C, right? And what's exciting about that to me is, what is clinic B doing so well that clinic A can learn from, right? How can we find the best practices that are being done at each site so that we can amplify this and get the best care throughout the health system? So we're working on a lot of different enterprise architecture, and also continuing to build our opportunities in behavioral health integration. So improving our registry so that the reporting is seamless, and being able to really amplify our efforts with TBHI, or again, technology-enabled behavioral health integration, is where all of our efforts are really going to be focused on, because that's where the future is in behavioral health, to meet the growing needs of patients.
And then, it's obviously great to, be able to share across the platform, but then that raises the question about security. We've seen a lot of issues recently. Particularly we've seen things with malware where, all that craziness. So how do you address security? Because you're dealing obviously with sensitive information. Can you talk about that, please?
Yeah, for sure. I can take a stab at it as much as the clinical guy on the team can, but what I can always say is, our company was really founded working with the VA, right? So it was through National Science Foundation grant. So from the start, security was our number one, because to even get our foot in the door in the VA, you have to think about a FedRAMP compliance and how do you meet these SOC 2 requirements, right, that everyone needs to meet. So we're built on a really modern stack, right, using AWS, the best security that AWS has to offer. Everything's encrypted, whether it's in transit or at rest. And that's always what's on top of mind for us. So, I'm sure I could probably try and take a stab a little bit deeper than that, but,
No, you used enough acronyms that no one understood. So
that was right. Yeah. As long as someone was lost in that I did my job. Working with the DoD now.
Whenever you use SOC, I know we've gone too far, so.
Good. No, that's great. It makes me feel dangerous now.
Yeah.
But it's exciting. The DoD, we're working on, we're already on FedRAMP compliant servers, but now making sure the whole product's FedRAMP compliant so that we can continue to grow and scale in the federal market.
And are you available in multiple languages or just English at this point? Where are you with that?
Yeah, primarily in English, although, we're always open to opportunities. It's just more been that's where our, primary locations have been, but we're certainly open looking at Spanish, certainly, especially in questionnaires and assessments and things like that can be available. But as far as the primary platform right now, it's primarily English.
And are you focused in the Northeast? Are you throughout the country or any particular geographic areas or specialties?
Yeah, no, we're nationwide. At last check, we're in 35 of the 50 states. But I would say there's pockets here or there where we're probably more, have more saturated than others. But certainly, I would say we are national now, no longer a regional play.
And one of the concerns with a lot of the new technologies is reaching areas that aren't technologically served, right, where they don't have internet. How do you address, can you address areas that don't have the technology? How do you deal with that?
For sure. That's actually one area working with the Air Force we're looking at, right? Because we know when people go off on deployments, Wi-Fi is a luxury at that point, right? Mm-hmm. So we're building things like offline mode where you'll be able to actually, use the platform even if you're not connected to connection. So that's coming. That's on our roadmap. But the idea here now is we can work on pretty low bandwidth. So being able to, as long as you have any sort of connectivity, it doesn't have to be broadband, right? To be able to connect through data plans, you'll be able to access the resources.
So what would you suggest to somebody who hasn't tried your platform, has some concerns around the stigma of mental health? How would you recommend your platform to somebody like that?
Yeah, I would say, it's not about mental illness. It's about helping you with your performance, right? It's about making you the best person that you can be. And what we're here to do is not tell you what behaviors you need to change. It's helping you to identify the behaviors that you want to change and helping you set those goals to get there. So, it has nothing to do with the treatment of mental illness. We're not a digital therapeutic. What we're here to do is help guide you and maybe help you identify what's going on in your life, give you some suggestions, and then, help you set goals so that you can start feeling better. And not just better in the sense that you were feeling bad, but better as in the sense that there's always more to improve on. And that's a journey I hope that we're all want to be on throughout our lives, is becoming a better person where we're able to perform better at work and be better for our families when we're back home.
And on a sort of a closing, we've seen a fair amount of funding around digital health in the current environment. And there's concerns that as we return to normal, whatever normal may be, that funding may wane. What's your sense, any insights or thoughts about that as to, what does returning to normal mean and how does it impact, what we're all working on?
Yeah, I don't know that there is a normal, right? The pendulum may have swung, but it's never swinging back all the way across again. We're in a new world. We've crossed the threshold of digital health being one of the primary delivery methods of healthcare. So while I assume that it's a red hot market right now, maybe it won't be so red hot, but it certainly will remain hot because this is the area where we need to continue to advance on in order to meet the needs of a healthcare system that has the highest cost per capita of any country on earth, right? Digital health and technology is part of the solution. It might not be the only part of the solution, but it's certainly a big part of driving down costs here in the United States, and a big part about how we can increase access to not just mental health care, but all healthcare. So I certainly see it as still being something that we're going to need and continue to grow even beyond the pandemic world that we live in.
So if you were to be approached by a startup that's new in the space, in the digital health space, what kind of advice would you offer them?
Yeah, that's a great question. What would I tell myself, I guess, a few years ago, right? I think it's to be flexible. You can't come in and think that you know what your role is, because if you're rigid and you think that this is my space and this is where I'm going to work and this is what I do, you're going to get jaded and you're going to get frustrated, and that's not how it works. So you have to be able to be flexible, be willing to wear different hats, and be excited about it, right? I think I love coming to work because I like the people I work with. So it doesn't feel like work every day. To me, it's, sure, we work late hours, but I work late hours with people I kind of want to be around. And we're talking about really cool, innovative solutions to problems that I've wanted to address my entire adult life. So this doesn't feel like a challenge to me. It feels like a fun journey with people I really want to work with. So I'd say surround yourself with the people you want to be with, and be flexible in understanding that your role might change day to day.
Matt, we very much appreciate your insights. We'll keep that advice in mind as we're launching our startups. We appreciate you sharing with us some information about NeuroFlow and all the exciting stuff that you're working on. We look forward to some big things in the near future, and we'll get this up online and we will be chatting with you soon. Thanks, Matt.
Great. Yeah, thanks, Mike. Appreciate it.
Thank you.